All right, welcome to SGU's Emergency Medical Club Airway Management. We're going to be breaking this down into a couple pieces regarding airway devices that we're going to be using, as well as common equipment that you will be seeing as well as using in these maneuvers. So we're splitting this into blind insertion devices as well as laryngoscope guided intubation. So with the blind insertion devices, we have two supraglottic airways. We have the King laryngeal tube, or the King LT, and we have the laryngeal mask airway. So starting off with the anatomy of the King LT from top to bottom, we have the tube that allows air into the bulbs to fill the bulbs. We have the caps at the top in order to attach a bag to. We have a conduit to pass nasogastric tubes. We have insertion distances in centimeters. And we have the volume of air required to inflate the tubes themselves and the size of the tube. Here we have the proximal bulb, we have the ventilation tubes, and the distal bulb. So in terms of insertion, you want to make sure that the bulbs are patent and there's no leaking of air. So because it says 30 to 70 milliliters on the tube itself, I'm going to grab my syringe. I'm going to stick it on, and I'm going to pump about 50 milliliters of air to make sure that the bulbs inflate and there's no leaking of air. Go. Now in terms of insertion, you want to make sure that the ends are properly lubricated. So I've already pre-lubed them. You are performing a head tilt, chin lift. You're coming in at about a 45-degree angle, and then you can rotate to midline as you get it farther in. Now ideally, the cap of the tube should be flush near the teeth, so because of the mannequin that we're using, this is as far down as it's going to sit. Now that distal tube is sitting at the opening of the esophagus. So once inflated, we're going to make sure we stabilize the tube. Once inflated, the bulb at the distal tip is going to block the esophagus. The bulb at the proximal tip is going to block the larynx, so that when we pass air through, it should be going directly into the trachea. So we're going to inflate to make sure the tube itself is secure. 50 mils. And now we're going to bag to look for symmetrical bilateral chest rise. Auscultation bilaterally also helps confirm air entry into the lungs. In terms of removal, you want to make sure to remove the air from the tube before taking it out. And then remove your King LT airway. Ready? All right, so the LMA is very similar to the King LT. LMA stands for laryngeal mask airway. Very similar in terms of it having a tube that allows air in to fill the cuff. It has the markings for insertion distance, and it has the volume in which you should insert. So now for the cuff, you have the distal tip of the cuff and the proximal end of the cuff. The distal tip sits in the entrance to the esophagus, and the proximal cuff sits at the entrance or the end of the larynx. So when inflated, air is being pushed into the trachea. Some LMAs also allow for passage of an endotracheal tube into the LMA itself and into the trachea. So pre-lubed. For this, you can insert and use your finger to guide the LMA down into the trachea. As you're going in, you make sure to stabilize. Be careful not to kink the tube when you're stabilizing with your tube holder. You're going to inflate the cuffs. Once the airway is secure, just like with the king laryngeal tube, you're going to bag for bilateral chest rise. Auscultation in both lung fields to confirm. Now, as we are removing, some indications to using blind insertion devices are when there is a patient with no pulse, isn't breathing, has any sort of potential facial deformities, or a thick, heavy beard that makes BVM bagging difficult, as well as inaccessibility or alternatives to endotracheal tubes. Some contraindications to using blind insertion devices, like an LMA and a King LT, is if the patient has esophageal disease or if they are responsive and have an intact gag reflex. Now, as we're moving to laryngoscope guided intubation, we have 3 sizes of endotracheal tubes. It's a good idea to get a gauge for the size you want to use and then get one size below and one size above, just so if you're trying to intubate and it's not going in, you're not fumbling around trying to find the right size when this is a patient in respiratory distress that needs active oxygenation. So in terms of the anatomy of an ET tube, same cap at the top attaches to your BVM. The insertion distances in centimeters. All adult ET tubes are filled to the cuff with 10 milliliters of oxygen. You have your distal cuff, you have your eye of Murphy, and you have your distal end. Now the eye of Murphy is there so that if there's an obstruction at the distal end, there's still an alternative conduit for ventilation. So I'm going to prep my ET tube with a stylet to make sure that I give some rigidity to help with guiding that ET tube into the trachea. I'm gonna give it sort of a hockey stick kind of look so that I can curve into the trachea when I'm ready. I'm gonna have this at my side, and then I'm gonna get my handles ready. So I have my handle and my blades. This is your laryngoscope handle, and these are 2 examples of blades. One is a Mac 4 and one is a Miller 3. The Mac blades are curved, the Miller blades are straight. You can think of the C in the Mac to represent the curve, and the straight L in the Miller to represent the straightness of the blade itself. The purpose and the use of each blade, the curved Mac blade is supposed to go in and sit anterior to the epiglottis, right in the vallecula. So when you are lifting up, it helps move the epiglottis out of the way. For the Miller, you are using the blade itself to sit under the tongue and the distal tip to touch the epiglottis, so you're moving everything out of the way in its entirety. Now, if you look at the guide along the side of each blade, you'll notice that there's a groove on the right side of the blade. This means this is a right-sided blade. You're going to be holding right-sided blades with your left hand, and the intubation is being performed with your right hand. That's why it's called a right-sided blade. So now, when you are attaching the handle to the blade, you want to make sure that it is white, tight, and bright. So you want to make sure that the light is nice, shining, and white. You want to make sure it's tight. Some non-fibroscopic handles actually screw the light into it, and you want to make sure it's bright and steady so that the batteries are good and there's not going to be any flickering when you're ready to go into the patient's mouth. You can cut it here. So now with blade and handle in hand, you're going to be performing your same head tilt chin lift, and you're going to be using the Mac blade to go in and sit right into the patient's vallecula. Now, as you're going in, you want to make sure to cheers, not chug. Cheers is in you're going to be pulling up and away from you. If you tilt back and chug, there's a chance that you might be breaking the patient's teeth. So you want to make sure that you're gripping low down on the handle and you're pulling up and away. Once you're able to visualize the vocal cords, you want to make sure to grab your ET tube. You're coming in. Once you're sure that you're inside the trachea, using the measurements, since this is a 7.5 tube, a nice rule of thumb is to multiply 7.5 by 3, and that's going to put us at 22.5. And you can pull back a little bit to make sure we're sitting at 22.5 on the measurement to know that the distal end of the endotracheal tube is sitting at the carina just before the bifurcation of the bronchus. So now that I have this, I'm going to stabilize. Take my stylet out. I'm going to inflate the cuff. 10 mils of oxygen. And I'm going to turn on oxygen and bag to ensure bilateral chest rise. We're going to confirm with auscultation. And another way we can confirm is using colorimetric CO2 detectors, which can attach directly onto the endotracheal tube, attached to the bag, and using positive pressure ventilation when we're bagging. After about 5 or 6 breaths, we get a feedback that's going to change the color on the capnography from purple to yellow. Because it's already been used, it's showing up as yellow. But once there is some sort of feedback of carbon dioxide from the lungs, it'll change the color from purple to yellow.